Good afternoon, everyone. My name is Dr. Raquel Romero, and I'm going to be the facilitator for the ECHO session today. Thank you for joining the Communicating with Confianza, a Health Literacy ECHO. This ECHO is brought to you by the Health Confianza team in collaboration with UT Health San Antonio, SuperHub, the YWCA, the South Central EHEC, and the University of Texas at Austin. For those that don't know who we are, Health Confianza is a community-wide health literacy program that aims to provide health literacy, education, training, resources, and workforce development for Bejar County and the surrounding areas. Our team believes that health literacy is critical to transform health and achieve health equity for all. Kindly, I would like to remind you that these sessions build upon each other, so I highly encourage to attend each session to improve your learning experience. I invite you to come to see and hear what we have been prepared for you. The second part of the ECHO session is devoted to have a dynamic discussion related and real life scenario presented by a member of our community. To ensure privacy, please note that no personal health information is allowed to disclose at any point of this session. So no PHI. So what is the PHI? Well, is DOB, date of birth, addresses, appointment dates, etc. So before we go to the introductions of our team, I would like to ask you if you please enter your name, your affiliation, and your email in the chat. This is for our attendance records. Also, you can rename yourself in the Zoom that reflects your first and your last name. And please stay muted only you are speaking. But we encourage to all of you participate in our discussion today by using the chat or join us by video if you feel comfortable in doing so. If you have any connection, we have an IT person. You can send a message to our IT for today. So finally, ECHO is an all teach, all learn environment. We encourage you to participate in our conversation today and in our discussion today. So let me go ahead and go to the introductions. And we're going to do the introductions to our team. And I would like to start with, let me see, Connie Reyes. She's going to be our leader specialist. Thank you.
Hey everybody, Corinne Reyes, YWCA San Antonio, and also a Health Confianza Pledge Program member as well. Good to meet everybody.
Thank you so much. As I said, she's going to be our leader specialist. We have Dr. Adelita Cantu.
Good morning or good afternoon, everyone. Thank you for joining us. My name is Adelita Cantu. I'm a professor at UT San Antonio School of Nursing. Happy to see so many people here and working with Dr. Rosenfeld, Corinne, and others on Health Confianza. Thank you.
Thank you very much, Dr. Melanie Stone.
Hey everyone, great to see you. Thanks for those of you who are continuing to join us on the series and our new faces today. So I'm Melanie Stone. I am a professor at UT Health San Antonio, and I co-direct Health Confianza. I did want to make sure you saw the advertisement for our Health Confianza Summit coming up on May 15th. We hope you will register and come to that event as well. It's good to see you.
Yeah, thank you so much for that announcement, Dr. Stone. Yeah, please come and register for that event. For today, we have Dr. Carolina Schlenker. She's going to be presenting the didactics for today. Dr. Carolina, will you please unmute yourself and introduce yourself? And you are muted, Dr. Schlenker.
Hi, I'm Carolina Gonzalez Schlenker. I am adjunct professor community family and community medicine, and I work with the promoters program at a primary care clinic in downtown San Antonio for many years. So thank you for having me today.
Thank you for presenting today. And part of our presenters, we have a case presenter, Frank Espinosa, is presenting the case.
Good afternoon. I'm Frank Espinosa. I'm a community health worker at Impacto Comunitario, and I just joined the group, actually.
Well, thank you for presenting the case. As I always say, this is a very important also part of the ECHO, and I want to take a second just to remind everyone if you have a case to present or consider presenting a case, please contact us, and we want to hear from you. So with that, nothing from my end. I would like to give this space to Dr. Carolina Schlenker. She's going to be presenting the didactics. Thank you so much.
Okay. Should I share my screen now?
Yes, you end your time. Yes. Thank you.
Okay, can you see it? Well, hello, and thanks for the opportunity to share our work, what we have called the Nosotros approach. An interprofessional teamwork requires us to become that we for the sake of our patient. But as many as you might have experienced, either as a health professional or as a patient, navigating our fragmented healthcare has become more and more difficult. So today, I want to talk first about solidarity and to bring you to what was the explicit ethical framework of our approach from the beginning, to take you deep into the barriers that solidarity faces in our culture and invite you to believe that it is latent in all of us. Then I like to talk about how the scope of the promotores' work complemented the pathogenic view of medicine with that of salutogenesis, and how these two frameworks became the glue that created that we of interprofessional work, a we that existed beyond the duties required by the clinic administration and contracts, and the harm also that caused by poverty in our patients, as a story of care, a flexible live agreement that adapted to unexpected threats and opportunities. So then we'll have Frank present a case. Let's begin with the solidarity framework and begin with the framework used by the World Health Organization in the report more than 15 years ago that made social determinants of health part of our healthcare system, demanding us to figure out how society gets under our skin and harms us. Society is a sum of all our interactions, and to improve it, we must become critically aware of the implicit and explicit norms that we follow. Our society is grounded in the libertarian tradition that people are created equal, where freedom should be given to individuals as long as it doesn't interfere with the freedom of others. Commerce and the market economy guide structures, and economic growth is our proxy for social well-being. We get basic needs with money, we work for money, we pay taxes, we get punished with fines and rewarded by bonuses, and we measure each other's value with an economic hierarchy that assumes that is a result of effort and talent in competitive fields. But economic transactions tend to split our futures and leave out things that are not merchandises and that we value the most, like all that we are and do for love, for friendship, and for solidarity. So tracking the health outcome is still a work in progress. We began with the single disease and the single cause in germ theory, then to single disease and multiple causes like heart disease, single disease and multiple diseases like poverty. And right now we're figuring out multiple causes with multiple diseases, trying to come up with cost effectiveness analysis, population health management, to allocate our financial resources, and having a lot of trouble with that. What are the boundaries of our work? What are its goals? How are they affected by social factors? What is the organizing of society that makes us sick? Is health functioning in a dysfunctional world? Well, at the beginning of our program, we tested this. We used the ICF, which measures the health outcome at its broadest way. Our promotores assess different areas of our patients' lives, But what we found was that there was no healthy adaptation to poverty, not just in terms of lacking the material needs and having to live in survival mode, but in lacking a sense of agency in the social structures that determined our future. A lot of what we found was people spend their lives just trying to make do to survive, and on top of being ill. So if we go back to redlining almost 100 years ago, the same logic was made when financial institutions denied loans to non-whites that had been impoverished, and that continues on as our culture allows us to morally disengage in the presence of poverty. The fact that our patient is not seen by the doctor because she cannot afford a copay does not get to our ethics committee. We see poverty as unfortunate, but not as unjust. Economic theory is based on game theory. So being poor is losing a game of rivals. Nelson Mandela makes us think otherwise. And Adela Cortina coined the term aporophobia to describe the dilemma that our culture cannot solve and accelerate it in ways that has most of us now feeling unable to project a future. So with money as the value metric of the human, we have a hard time figuring out the value of health. We have come up with DALYs and QALYs. DALYs are measure the burden of disease in a society using, weighting the state of health by the economic productivity of the person. QALYs measure the quality of life in a given state using economic discount rates. These measures subsume, put under money the health outcome, and cannot be used. We cannot say we're using money to pay for healthcare when the definition of health includes money. So we need to create new approaches to value health outcomes that these metrics have not been able to be good enough. We are in sort of a disorienting state after decades of studies and research on health inequities that demand an ethical imperative for social change. However, we are having a dynamic system driven towards greater inequities, economic stress, polarization, generalized distrust. The social fabric of society seems to be at risk. And we have evidence, both transdisciplinary and transcultural, that we produce most of each other's harm and well-being. So we need to braid our stories into a new social fabric, one of a shared future. That's what our youth is asking for. That is why we urgently need to expand the view and believe that we can bring about solidarity. Like it's said, we cannot solve our problems with the same thinking we use to create them. And the moral compass has been to move from equality to equity, in which we need to adapt to the persons that need that extra help. But even beyond that, we still have trouble defining justice. We must come up with some ways to ground ourselves in reasoning from the body. That's what the new theories of justice are recommended, so that we see each other as vulnerable, and that we need to look at things from the level of vulnerability, which is where trust is built. When we are vulnerable, information that is valuable flows that help us to have less prediction errors on what we do. And it is vulnerability that moves our hearts to love, to care, and to solidarity. So we must transition to a planetary culture by finding the humanity in each other, that our narrow economic view blinds us to, and that's what our youth is asking for. Donald Berwick, who was the director of Medicare and Medicaid, tells us that we must go beyond the social determinants of health into the moral determinants of health. And how do we move towards that change? It says solidarity would mean that individuals in the US legitimately and properly can depend on each other to help secure the basic circumstances of healthy lives. How do we move in that direction towards that change? What skills we need to live what he calls the moral law within us? Here is where we can add our second framework, which was grounded in the capacity of the promotores to work from the heart with their solidarity. Antonovsky wanted to understand why some people stay healthy while enduring stress. And he studied healthy people in different cultures in different parts of the world and came up with his theory of salutogenesis. He claimed that people go through hardship and will stay healthy if they can keep a sense of coherence, if there were resources around them that kept their lives comprehensible, manageable, and meaningful. But when we look at how we interact with healthcare, we see that what we see one patient at a time, and our protocols are mostly repair work of what went wrong below the skin. We practice protocols of care based on scientific evidence, and then becomes standards of quality and determines what gets covered or not by insurance. But what makes the patient's life salutogenic is very personal. It can have infinite variables, and we have trouble with this. Yet healthcare can neither ignore or fix the challenges that face our patients out there. So Nosotros' approach is about trust building, and it sees the unit of health not as the individual, but as an interaction that answers 4 questions: what we want, why we want it, what we do, and what we get. That is how our promotores created trust with their patients. That is how their interactions became salutogenic. But here's the key feature of the unit. And nosotros move at its own time. Sometimes goes faster than clock time, sometimes goes slower than the clock, because its outcome is unpredictable. The interaction takes a life of its own and gives access to information that the participants did not have before it. That is what is called participatory sense making, and that is what our patients value. So a dialogue must be found between 2 types of value. One linear that we can call accounting, and an organic one, which make us trustworthy, accountable to each other. And we put this approach to practice for almost 14 years at the Robert B. Greene. In our department chair, Dr. Carlos Jaén, and our chair of research, Dr. Bob Ferrer, protected the experiment and found funding for our work. So the promotores focus on making sure that whatever the clinic did for the patient was salutogenic, as they achieved a sense of agency we called self-care generativity. So they made sure that the plan of care expected by the PCP was comprehensible, manageable, and meaningful, and that the patient understood it, could do it, and matter. That is what made, let me just close this. So that's what we call self-care generativity. When things got difficult, promotores went out to all the different professionals inside the clinic that were involved in the plan of care. But not just inside the clinic, they also went out in the patient's life. And they got answers for their questions. And what we found was that in the structures of the healthcare system, as well as out there, the resources were not there. And we saw many patients unable to stay healthy. When they didn't understand, the promotores worked at it and got resources and learned. And then the patient was predictable and they could commit to things. When they could not do it, the promoters worked at it. The resources were found, people learned and predicted and commit to it. But if there was no solidarity and there was no resources and there was no learning, then we saw patients falling into toxic stress, loss of meaning, and no prediction and no purpose. And that is when we really grieved, despite all what we did and tried to build trust. We saw I heard thousands of stories from the promotores of how poverty takes away that sense of coherence, making meaning impossible. Promotores try to reverse that harm by helping patients make sense of things, imagining how things could change, and engaging everyone involved. As they were able to make a difference with little resources. In our study of diabetes patients, we made an impact in about a third of them. We published the study. We published the result, and we achieved cell generativity that improved the A1C. For the 10th measurement, our patient in cell generativity had less visits to the hospitals and to the emergency rooms. But what happened to that other 2/3? And also, this study was done almost 10 years ago. It ended out in 2017. From then until last year, things had gotten worse for our patients. Yet, promotores kept creating trust and accountability, a story of care that made our interprofessional teams' care fall into fertile ground. These professionals were not only our clinicians, they included everyone in the system that learned about the story of need and went the extra mile to help the patient, including people in administration. There was always a tension with the lack of resources and the gaps of love and care that poverty creates in homes and communities. But promotores kept that glue that allowed the synergy of different people, professional and non-professional. But then things accelerated in the culture, both inside healthcare and outside, and the linear value took over. However, Medicare, with all its good intentions, introduced funding for promotores work. The risk that we have now is that it makes that work standardized metrics and less free to navigate at its own time. The social determinants of health, or Z codes, were introduced in 2024. And if you see, they represent very complex life experiences that are to be documented in the electronic health record by the clinician. Then the clinician is supposed to put it in a code and then to produce revenue and then keep the promotores employed, which our department needs. So the focus have changed, and the protection for building trust one nosotros at a time had been lost, and the glue that could bring synergy of our interprofessional team into a story of care got weakened because there is less time to get the stories that made that glue. However, look at the language that Medicare and Medicaid is using. There is a lot of potential between these two values to enter into dialogue. We need creativity and we need to keep exploring. Medicare and Medicaid will benefit from introducing the frameworks of solidarity and salutogenesis because it worked for us. It created the synergy. However, solidarity in our institutions cannot replace the love in the homes and the care in communities. And our economic system is making those primary life-giving experiences very difficult. The cultural change that trust-building skills could bring about need to be at all levels. The nosotros needs to plant seeds in the community, in places like Impacto Comunitario, where Frank works, where we have a pilot now, where time still runs in terms of working from the heart. I want to leave you with a tool that we use to analyze cases and the levels of relational value called the future-oriented EcoMap. Our promotores detected and connected the solidarity of our clinicians to what made the patient care for themselves, to the love that often existed at homes, and to the caring of family and friends. With all those participating in the story of care, promotores kept a live agreement. When different heart joins to bring about a shared future that responded to the threats and opportunities as they appeared. That live agreement that went beyond the standards and the contracts that our clinicians had to comply with, to adapt to the patient's story, showed us that solidarity in healthcare is possible. We had always a positive response from every single individual in our institution to the story of need and to be part of that solidarity that the promotores were able to put together. There is also some frameworks proposed to integrate the data in a systematic way that need to be tested, like the 5 A's, where awareness triggers a response from healthcare. We are now testing how updates in the EcoMap that the promotores are bringing at Impacto can inform the awareness and show that solidarity can gradually change how our healthcare system responds. So what I want you to take home as a message is that there is a lot of opportunity, a lot of room to future together between healthcare and the community, so that we keep the trust of our patients and of our public. I'm going to leave you with my email. I know these are complex topics, but given the situation we're facing, I wanted to go there. Feel free to send me an email if you want to expand on any of these things I said. But now I leave you with Frank, which can share his experience using the Nosotros model at Impacto Comunitario. Thank you, Frank.
Thank you. Thank you so much, Dr. Schlenker. Thank you so much, and thank you for this presentation. And before we go to the case presentation, just would like to ask the audience, do you have any questions, any comments to Dr. Schlenker in regards to the presentation. Dr. Cantu?
Yes, I do have one question with your work at the Robert B. Greene,
Mhm.
Brady. I was there when it was called the Brady, the old Brady, one of my
Yeah.
favorite
Yeah.
jobs there. But I was wondering, I know the community health workers were part of the team that would deliver care and connect into resources. But I'm wondering about the bridge from the provider to the community health worker. Did the provider like have a prescription? How does the community health worker know that this individual, this patient needs the connections that you could provide them? I'm just wondering, was there a standard way of
Yeah.
provider
Yeah.
communicating that?
Yeah. Basically, our clinicians were aware that we could go figure things out because they have 15 minutes to interact with the patient. So any sense of uncertainty that will come at the moment of interaction, they realize this patient is either do not understand or will not be able. Just think of the three things in salutogenic. Did the patient understand? Uh-oh, maybe didn't. Did the patient, where will the patient be able to do what I'm expecting it to do? I'm getting all the messages that he won't. Or does the patient doesn't seem to be motivated because he comes again and again with the same problem? So any time that any of those three things pop into the provider's care, they send me a referral. Then I will go into the case at Epic and study the case. And then I realize, okay, what do we know about this human being? I handed the case to the promotor or the promotora and said, go knock at that door and tell them your providers care about you. That's why I'm here. That opened the heart of the patient. It's like, your doctor sent me? That is amazing. But not just that. Sometimes we took the residents there. We took the doctors there. But here is where the interprofessional teamwork was amazing. Whatever was the question that they didn't understand or they could not manage, we just went to them. And if you saw that picture, that slide where it has all these little people, we touch everyone. But you cannot touch them all at the same time. You only touch the ones related to the story of care, right? And that's where the nosotros becomes a very handy tool, because if it's something about medication, we're just going to go to the pharmacist. If it's something that I don't have money for the copay, we're going to go to the financial assistants and say, how can we figure this out and still get this patient in? If we went to the referral, so it was that story that pulled in the team into this we, and then everybody felt that they were all in one team. And we never had a no from anyone, even in administration. Everybody went the extra mile, and that was the beauty of it. So it was total solidarity, and that's what keeps me hopeful, because I know people in the system do care. They do care. We had an awesome set of residents, faculty, staff that went the extra mile once they felt they could be part of the story.
Thank you very much, Dr. Schlenker. And I also have a question. The Robert B. Greene, the RBG, so
Yes.
we all know the clinic is unique. Is very unique. But you have this model of interprofessional teamwork in that. How can others replicate this model?
And here is where my concern is. It is awesome that Medicare and Medicaid are taking into account the social determinants. But the problem is that the framework of healthcare is very administrative driven. So then it becomes a standardization of all these social determinants. Okay, does he have transportation? Does he have food insecurity? Does he have this? And it's a checkboxing thing that the promoters need to do, because now it's demanded by Medicare. but they don't have time to get to the story, because now it's a standard checkboxing that now we want every patient to be asked for. So it became less organic in the sense that it wasn't the provider that referred the patient. Is still trying to play both roles, but the pressure of getting the revenue from Medicare has made it harder. But not just healthcare is under that. Also, our patients are facing more hardship out there. So it's like practically everyone is facing a lot of these problems, like housing is difficult, food insecurity is difficult. I think like over 70% of our patients are facing food insecurity. How do we deal with this? And healthcare is not going to be able to fix this, right? But so how do we all as a community figure out that we can do better? We can do better than just, saying no because we don't have the money. We need to get creative. And I think healthcare can trigger this, because that is where people that care about the suffering of others are professionally situated. Nursing is tremendous on that. And they have, been pioneers on the ethics of care, yet that ethics remains very principle-based and doesn't allow that expansion that we are asking for. So it's not easy.
Thank you very much for that. So I will ask again to our audience, do you have any question, any comment, any that you would like to ask? If not now, you may want to think on it and put in the chat. So we're going to be here for the rest of the hour. But I want to use the now. Oh, Miss Marta Castilla.
Yes, ma'am. I want to share that I worked with the Nosotros when we had I had a nonprofit that would do home visits. We would visit the elderly, and just the fact that a neighbor was coming because we cared about them and cared about their health, it was very strong, and it helped them to try to do what the doctor told them as far as taking medication, trying to eat the right foods. And just the fact that we were there to see them, because a lot of times they have visits, but it's for other members of the family. But when it was for them, we would say the name and they said, yeah, that's for me. So that brought them a lot of peace, a lot of hope. And that's something that we all want to do, but we don't have time to do it. But when you have a program that gives time for people to understand the story behind the data, you can really get down to the root causes of what's really happening with these patients. And yes, sometimes they don't understand. Sometimes they're embarrassed to speak English. Sometimes they're embarrassed to admit that they don't understand what the doctor's telling them. And sometimes what they're being told is difficult for them to do unless there's resources. And as community health workers, we can connect them to those resources, whether it's health fairs or, health fairs or food drives. We can bring them the things that they're lacking. But just the fact that someone cares around their community, it's something big for them. Thank you. And kudos for all the doctors and all these people, because I know that we used to deliver food every Monday. We started with 7 homes of seniors and it grew to 100. But I also had a nurse that would go with me like once a month, and she would check things, what they were worried about. And that really brought them peace also. And Marta Martinez was a nurse that used to go with me and her students. And the students loved that opportunity to see how community really lives and the reality of that. Thank you.
Thank you very much. There is also a message in the chat. It says true in capital letters. Ana Torres, a big Mama Safe House. It is so important someone hear the stories. We all want to be heard. and they will somewhere pay attention to us, particularly dealing with health conditions, right? Because it can be very overwhelming for everybody when we face a new diagnosis, and it's part of the heart of this Confianza, the health literacy, trying to get those values, right? And I know the community health workers are doing beautiful work, always, always. We all need that. With that, if that's okay, we can now move to the case. Frank Espinosa have a case presenting today. Thank you.
Okay. Good afternoon. Thank you for the opportunity to go over this case. As a promoter, CHW, I was made responsible to contact Alex, a teen patient that was sent by his doctor to the ER due to alarming lab results. He has out of control diabetes. He had no showed to appointments. He hadn't picked up his meds. He refused the glucose monitor, and the clinic could not reach him. So I saw that Alex lives in an unsafe part of town. His 18th birthday had just passed, so I got him a gift. The clinic informed me that Alex lived with mom and he's a senior in high school. I called all the contact info without response. I decided to look for them at home on a Sunday afternoon because it was more likely to find them on a Sunday afternoon. So I found that the gate was locked. I couldn't knock on the door. I called Alex. I called his mom again, no answer. Then I called the grandmother, who was listed as an emergency contact, and she answered. I identified myself as coming from the clinic, told her I had a gift for her grandson. She called him, so they came to the gate and we talked. They expressed deep discontent with their health care. From that point on, our relationship developed, and I have been able to connect Alex and mom to the different professionals that care about him. My supervisor of the Ilusión program at Impacto, the doctor that leads the Ilusión program, the endocrinologist that treats his diabetes, the social worker that helped him secure his Medicaid as an adult, the nutritionist that advised him and mom on his diet, the pharmacist that instructs him on using the monitor. I visited him at school. I'm informed of his activities there and have gotten to understand Alex's story in ways that I can help the professionals care to work for him effectively. And they've all been responsive. So as far as the question, how did you handle the situation in the moment? I was feeling discouraged when I could not reach him and did not know what to think. But once I had Alex and mom in front of me, everything changed. I was able to see their frustration. I listened to them so I could understand what happened. I made no attempt to justify the bad experience they were describing. I made a note of their worries. I promised them I will find out how the situation could be improved. So these questions, what went well, what went less well? What went well, I really wanted to help Alex. That's something that I really wanted to do. I was patient and kept trying. I listened and I was not judgmental of either side. What went less well, I felt awkward and uninformed. It was hard to stay impartial. As far as my questions, how do I remain impartial in the moment so I don't contribute to the loss of trust in both sides? Second question, how can promotores, CHWs be more effective, get more training to be liaisons, helping both patients and clinicians work together to improve patients' health, given the barriers they both face to connect their worlds? That's my presentation.
Thank you very much for explaining the case, the circumstances, and the context that helps to understand the person and the conditions that they are facing up. So, to the audience, is there any comment, question that we have for this case? How to remain impartial, like the first question, in situations like this? How you been facing that? If you have been facing that this situation, how you been handled? Would you please feel confident to share with us? And the question is in the chat. How do I remain impartial in the moment and don't contribute to the loss of trust in both sides, right? This is so important. The trust is part of, and the respect is part of this communication that we would like to start building up every time. Dr. Cantu?
Yes, again, thank you, Frank. Thank you for that. It's so some really insightful questions, and I'm wondering what the audience does think, and I'm wondering with that first question, is it best to stay impartial? I mean, part of that trust that we want to build up. Also, I think it's important to understand, to communicate, to empathize, to really listen. And I'm hoping that the person, whoever the patient would be, or whoever that person we're trying to help would be, then can understand some trust from my communication and maybe the not being so impartial. I don't know if that makes sense or not, but I'm wondering, where is that balance between, yes, do we need to be impartial or do we not in some situations? So it's a great, I mean, I don't know if you have an answer. I don't want an answer. It's just something I'm thinking about.
Let me just share a little bit, if I may. Many times since I was, supervising the promoters were in the field, what I would hear from the clinicians was frustration. You say, like, this kid doesn't care about him. This patient is not adhering with the medication. They're not showing. And, the doctor gets frustrated because they see their work as not making any impact. And you can understand that frustration, and they can become judgmental towards the patient. But if we know what's going on, then it's very hard sometimes for the promotores to say, doctor, don't judge them. They're going through all this stuff. But then the doctor doesn't have the time often to hear all this stuff that the promotores know. So we needed to do it very carefully and say, well, the patient is facing this thing right now. And we had to send that information right before the appointment so the doctor get it at the right time. But the same thing happened in the other side, like Frank said, is like our patient said, oh, these doctors don't care about me. All they want is money, and I don't want to go back there when they needed healthcare. So you are like, with your one foot in the clinic and one foot in the home, and the things become tense and you feel like you don't want to let go of either of them. You cannot just deny the experience of the doctor because it's true the patient has not done their side of self-care, but you can also deny the experience of the patient in where the healthcare system is just, abandoning them because they don't have this and that coverage, or because, they just cannot make it to the clinic. So here is these two worlds of people that care to achieve better health outcomes, and there's no dialogue, and that dialogue is becoming thinner. that is my concern, right? And now that Frank will stay impartial, it was not probably a best description because he did care. He said he showed the patient and his mom, I'm sorry this is happening, right? But then he also knew that the doctor was frustrated. But then is the information flow. That's what trust does. That then the information flows and this trust doesn't fall apart. That's the idea.
Yeah, very important how the communication is that continue, right? And yeah, being impartial versus have empathy, but keep the communication because touch our heart, right? For the circumstances and for the provider, yes, I will see that situation for the patient facing up a new diagnosis. I always say this is very complex and complicated. Dr. Stone, and then I'm gonna go with you, Corinne. But you have something in the chat about transparency in the situation. You would like to elaborate a little bit more?
Sure. I think a key skill that we try to talk about with our Health Confianza trainings is that we can't always control situations or be able to know even what the best evidence of a particular situation might be at a time because it's constantly changing. But just being transparent about that with our community members, our patients, I think is a lesson that we all learned from COVID-19, that transparency can go a long way to building that trust. And so that's the comment I was trying to make.
Yeah, thank you very much. Transparency, I know, and it acknowledge, right? So that is the situation. This is very, very important. Corinne, I promise to go with you after.
Yeah. I was thinking about what Dr. Schlenker said about the doctor feeling like they're sitting in judgment of the patient because they don't know what's going on, and then vice versa as well. The thing is, when I'm listening to you say this, all of the onus now gets placed on Frank to build that relationship. And Frank built that relationship. The doctor and the patient did not. And so that loop is going to continue if he's continuing to be placed as the go-between, because there's no actual relationship getting formed between the doctor and the patient. This is nobody's fault. This is just the healthcare system we're sitting in right now. I just wonder if, as we look towards the future, and especially with all the things you talked about today with moving from social determinants of health to an ethical determinants of health kind of structure, do we need to restructure that so that at the bare minimum, Frank, the doctor, and the patient can sit in a room together one time, and then have that conversation? Or do we need to, have once weekly case reviews with the doctors and the community health workers so that they can get a better understanding? I'm not sure what the answer is because we're just not there yet, but it's interesting. Basically, in my opinion, Frank got put as the person holding all the responsibility, and that's not really completely fair.
Yeah, I totally agree with you, and that's exactly what our promotores were doing. They were the bridge that was just about to break down, and we did have those case reviews. So whenever we brainstorm and we couldn't figure it out, we will bring the residents and the doctors and present the case using that EcoMap, that tool, so that the promoter will say, okay, this is how I'm trying to bridge this agreement between all these actors, but it's not working yet. What do you propose? And then we will brainstorm. And then somebody will come up with some bright idea, and then we will put it to test. So that was, we did that every Wednesday. One of the promoters will bring a case using the EcoMap, and it's just a nice illustration about, okay, who cares about this human being? Let's make the map. Okay, how can we strengthen those that care about this patient so that the caring doesn't fall apart, right? Here is where the interprofessional communication was awesome, because let's bring in the pharmacist, let's bring the social worker and support these promotores work, because they were at their wits' end. Sometimes we had to be an agency that was not part of the clinic, went to Saha, we went to all these other places, or we brought in a family member. But many times the promotor or promotora will sit at the appointment with the patient and the doctor and tell them both, doctor, could you please tell the patient this because he didn't understand? Or a patient, tell the doctor, because you're nodding your head, but you're not sharing this. And right in the moment, they did that thousands of times. But then the cases got, but that's because they built the trust. They were trusted by the clinicians, they were trusted by the patients, and then they could pull them into, okay, guys, talk, right? That takes time. And in order for the patient to open up to a stranger that knocks at your door, you need to move with your heart, with caring and respect. And that's the only way. And that takes time. And that takes its own time.
Takes time. Like Cynthia de la Garza, Parker's active listening impartially without internal judgment. Marta Castilla?
Yes, I wanted to say that it's very important to hold on to that relationship with the patient, trusting relationship, and communicate with the doctor until you have. Sometimes when you have to celebrate everything that's gone right. With a little thing that the patient does, you celebrate it. And then always bring someone from the family to continue and remind the patient. And that's great because sometimes it improves the relationships within the family. Another thing too is that the go back and tell the doctors are willing to work harder or do more or whatever because they heard what's happening and the numbers are better. That's all the doctor wants, that they get better. And so this relationship is really good, and it is to be transparent. And so, yes, at one point, Frank won't be in there in the middle, but at least he connected them and they understood each other, the patient and the doctor.
Marta, I really like when you say the doctors, they only want to them get better. Is the good intentions is about this communication. But of course, we have some limitations in time, but yeah, eventually, like you said.
Yeah, it's a limited time.
Yeah, Frank is gonna be there, but yeah, it's everyone has a genuine intentions and trying to help the person that is in front of us. Sean, Irwin, do you have a comment in the chat that you would like to elaborate a little bit more? Sean, Irwin.
Yeah, I'm here. I'm sorry. No, I think, I put in there compassion fatigue, and I remember when I started in this CHW social work field 10 years ago, like the first year I was all gun ho and, tried to save the world. But by year two, the same clients were coming in, and I rapidly realized that I had things in my closet and, negative thoughts that the client didn't care. They're back in for the same problem. We fixed this 6 months ago. Why are we doing it again? So it's really using that PTO, taking some time off, getting away, relaxing, whatever it is that that helps you put those negative thoughts back into your closet, so that when a client comes in, maybe with the same challenge, that you're not emotionally being negative toward that resident. And then emotional intelligence. Your facial expressions. Your nonverbal cues. And then what was the other thing I put on here? And then use a motivational interviewing for like the clients that don't understand. I'm huge. That's, trying to get them to solve their problems. Don't give them the answers to the test. If they feel like they, and I'm not saying anything nobody in this panel doesn't know, but, getting them to come to the conclusion rather than you solving their problems. I've seen better results once I started gearing them up to solve their own issues and giving them, options. Hey, how would you be in your life, or physically, emotionally, spiritually, emotionally, if you did A, B, or C? Let them try to choose their path, and you'll have a better outcome of them sticking to those answers. That was it, ma'am.
Well, thank you so much for that, because I think what you say is recognizing our own limitations, and we all are humans, right? So, but recognizing that sometimes we have those moments is so important, our self-reflection, but at the same time, the person be part of the decision making is very important because of the ownership. Thank you so much. We almost finished and we're at the tip of the hour, but I would like to go with Corinne Reyes if she can give us a summary of recommendations for this day.
This was a really great conversation. I really appreciated a lot of what everybody said. Frank, you had an amazing case story. Marta, you're so insightful. Sean, you had some really good things to say there. Like, this really brought everything home from us. Dr. Schlenker started us off learning about the Nosotros approach, which is an interactive approach that tells us what we want, why we want it, what we do, and what we get out of it. It's a trust building framework. And then it helps people to move from that part right there to I understand and I can do. That's a little bit what you were saying there, Sean, towards the end. Like, I can do it myself. And this is a form of participatory sense making. A really key function of this is a solidarity piece, because what she noted was we produce most of each other's harm and well-being, and to our own well-being within society. So we need to go beyond the social determinants of health and move to an ethical determinants of health framework. This is looking at accounting versus accountability by paying attention to everyone's own personal health journey and making it individual to them. And what and the most important part to me, because I have a big heart for promotores as one myself, but they are the glue that holds us all together. Unfortunately, what we're seeing right now is because funding has now been added to this pot, it's standardizing the metrics and moving us away from that fluid, purpose-driven response that promotores originally were designed to do. Institutional care cannot replace community, and we have to remember that in our work. She uses the 5 A's framework, which is adjust, assist, align, and advocacy, all through the lens of awareness, to encompass and understand the individual while working within the institutional setting. And thank you guys all very much for joining us. This was one of my favorite sessions so far. So awesome.
Thank you very much. That was a wonderful summary. Thank you so much, Judith. A wonderful summary of these recommendations, and also for the presentation, Dr. Schlenker. Thank you so much. Frank Espinosa, thank you for the case. And I always invite those persons that share the case, if in the future you would like to share a follow-up of the case. How did you manage the situations? How you will manage the case? It will be appreciated. Thank you so much for everyone that makes this session an amazing learning opportunity. And yes, adults don't want to be told what to do. So what were you saying, like a part of the decision making, self-care is important? Yes, Marta, yes, I promise to read all that message in the chat, and I did. So thank you so much, you all, for being with us today. And as a reminder, there is going to be some links in the chat, trying to see for the credits. And also, please stay with us and the 2 more weeks in March the 20th. So I invite you to come and see what we're going to be preparing for you. Thank you so much, and you have a wonderful rest of the day. Thank you.
Thank you.